So, today we'll begin a simple primary care review on hypertension. So, the normal blood pressure for systolic will be between 90 and 120 millimeters of mercury, and diastolic is between 50 and 80 millimeters of mercury. Elevated blood pressure, systolic blood pressure, would be 120 to 129 millimeters of mercury, and diastolic blood pressure would be less than 80 millimeters of mercury. In hypertension, stage 1, systolic would be around 130 to 139 millimeters of mercury, or diastolic would be 80 to 89 millimeters of mercury. Stage 2 would be systolic is at least 140 millimeters of mercury, or diastolic would be at least 90 millimeters of mercury. Hypertension is classified as two types based on its causes, which are primary hypertension and secondary hypertension. This classification can help the clinical management and treatment. Primary hypertension. Primary hypertension is the most common hypertension and likely the result of numerous genetic and environmental factors. Several risk factors are strongly and independently associated with its development. Risk factors for primary hypertension. Age. Advancing age is associated with increased blood pressure, particularly systolic blood pressure. And obesity and weight gain are major risk factors for hypertension. And a family history. Hypertension is approximately twice as common in people who have one or two hypertensive parents. High sodium diet. Excess sodium intake would be greater than 3 grams per day, increases the risk for hypertension. Excessive alcohol consumption. Excess alcohol intake is associated with the development of hypertension. And lastly, physical inactivity. Physical inactivity increases the risk for hypertension. Secondary hypertension is due to an unidentifiable cause. Secondary hypertension causes. Medications. Oral contraceptives, particularly higher doses of estrogen. Non-steroidal anti-inflammatory agents, particularly chronic use. Corticosteroids, decongestants such as phenylephrine and pseudoephedrine. Stimulants include methylphenidate and amphetamines, atypical antipsychotics, including clozapine and olanzapine. Kidney disease, both acute and chronic kidney disease, can lead to hypertension. Primary aldosteronism, obstructive sleep apnea, and endocrine disorders. In hyperthyroidism, and hyperparathyroidism. Complications of hypertension: a left ventricular hypertrophy, heart failure, ischemic stroke, intracerebral hemorrhage, ischemic heart disease, and chronic kidney disease and end-stage kidney disease. Clinical presentations: hypertension is asymptomatic until complications develop. Patients should be evaluated in the brain for stroke and dementia, heart, left ventricular heart, kidney, proteinuria, and chronic kidney disease, and eye for cotton wool exudates. Physical examination. Main goals of the physical examination are to evaluate for signs of end organ damage. The physical examination should include the fundoscopic examination to evaluate for hypertensive retinopathy. Laboratory testing. Electrolytes. including calcium and serum creatinine, fasting glucose, urinalysis, a complete blood count, thyroid stimulating hormones, lipid profile, electrocardiogram, and calculate the 10-year atherosclerotic cardiovascular disease risk. Initial management would be a lifestyle modification, dietary salt restriction, potassium supplementation, and weight loss, as weight loss can lead to a significant fall in blood pressure. The DASH diet, the dietary approaches to stop hypertension. This dietary pattern has a high in vegetables and fruits, low fat dairy products, whole grains, poultry, fish, and nuts, and low in sweets, sugar sweetened beverages, and red meats. Limited alcohol intake, and exercise, as exercise can decrease systolic and diastolic pressure on average to 4 to 6 millimeters of mercury or 3 millimeters of mercury, respectively. Initial drug treatment, thiazide type diuretics. Chlorthalidone, 12.5 to 25 milligrams taken daily, or hydrochlorothiazide would be 12.5 to 25 milligrams daily. Black patients and older adults, typically greater than or equal to 60 years, often respond better to a thiazide diuretic. Monitoring for the development of hypokalemia is warranted with all thiazide diuretics. Angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers will be needed in younger patients less than 50 years as they respond better to ACE inhibitors. The blood pressure should be assessed in 4 to 6 weeks. Calcium channel blockers. Black patients, older adults, or those with cardiovascular diseases often respond better to a long acting calcium channel blocker. The blood pressure should also be assessed in 4 to 6 weeks. The goal of treatment. The goal blood pressure in renal disease patients is less than 130 millimeters of mercury systolic and less than 80 millimeters of mercury diastolic, or less than 140 millimeters of mercury in systolic pressure and less than 90 millimeters of mercury in diastolic pressure in healthy patients. Severe hypertension. Severe hypertension is defined as a diastolic blood pressure that is above 120 millimeters of mercury in asymptomatic patients without acute end organ damage, which is referred to as hypertensive urgency. Thank you.